Hi, I'm Dr. Sam Mann, and this is Beyond Conventional Medical Thinking. Uh, today's discussion is about the guidelines again, the 2025 hypertension guidelines. In the previous podcast, we talked about initiation of therapy, which drugs. Today, we're going to talk about resistant hypertension that doesn't respond to the usual medication. What next? And so let's start with that. Definition of resistant hypertension is a blood pressure above 140 over 90 on three drugs. And those are the three drugs that are listed that we discussed last week: a diuretic, a calcium channel blocker, and an ACE inhibitor or ARB. The guidelines offer strategies to treat resistant hypertension, and we're going to review those strategies. And I'm going to mention the areas where I disagree with them. One thing I am going to emphasize, though, is also a treatment for resistant hypertension that is not even mentioned in the guidelines, and it is readily available, safe, wonderful combination, and we'll talk about that. So here's the story. We said hypertension resistant to the three drugs. So what do we do from that point? Well, first it says augment the diuretic, and then it gives a list of other treatment options. It gives the list that you see. And if that doesn't work, then it says consider renal denervation. So how do we pick the medication that might best fit the individual patient? And as we discussed the last time, first thing to consider is the mechanisms and the three main mechanisms underlying hypertension, and then figure out the medicine accordingly. The guidelines don't talk about the mechanisms and don't talk about individualizing. They just talk about a list of things you can try. So let's think mechanistically. And as we said, the three main mechanisms are the sodium volume mechanism, the renin-angiotensin system, and the third one is the sympathetic nervous system. So let's start first with the mechanism related to sodium volume. Decades ago, the usual dose of hydrochlorothiazide was 50, and as we said, now it's only 25. 50 has more adverse effects in terms of potassium, sodium, and other things. So that when we're treating with 25, we're not doing the whole job. We're doing a partial job, but it's not enough, particularly in patients whose hypertension is driven by sodium and volume. It's not enough. And the guidelines are telling us go on three drugs, and if that doesn't work, augment the diuretic regimen as the fourth step, as the fourth drug. So in other words, you're going to be on four drugs till you finally address fully the volume mechanism. And what I'm suggesting is if it's somebody who has clues that it is a volume-mediated hypertension, you don't need to add that drug and that drug. Augment the diuretic right away as the next step or the step after that. And there are good drugs to choose from. And you don't have to increase the hydrochlorothiazide. So what are the clues that tell us to augment the diuretic regimen? As we discussed last time, the major clues are Black population is more prone to volume-mediated hypertension, and augmenting the diuretic makes perfect sense earlier and not as a fourth drug. As we get older, we retain fluid a little more easily. Hypertension is more volume related. And then the other clue is the plasma renin activity, which few doctors check. A low plasma renin is telling us it's sodium volume mediated. Start with a diuretic or a calcium channel blocker. Don't rush to the ACE and ARB. Consider augmenting the diuretic. So those are the three clues that are helpful. Now, in augmenting the diuretic regimen, we have choices. As you can see in the guideline, it recommends a mineralocorticoid antagonist, specifically spironolactone, which is the most widely used. That class is okay, but I'm not crazy about it. For one, there are side effects. The uh, mineralocorticoid, the spironolactone, uh, it can cause breast tenderness in men, and I think women also. And it can raise potassium, but that's all right because it's protecting the potassium. Also can cause sexual dysfunction in a percentage of male recipients. So it's not my favorite drug. The interesting thing is on that list that had that list of drugs, there's a drug called amiloride. It's not a mineralocorticoid antagonist. It basically does not have side effects. It's rare and it's so well tolerated. It works just as well as spironolactone. And here is a study that shows that it worked just as well, doesn't have the side effects, is inexpensive, and it's a terrific drug to augment the hydrochlorothiazide. But it's just listed as one of many agents as a third, fourth choice. So how come, if it's such a great drug, why is most physicians are unaware of it? And that has to do with a couple of things. When they initiated that drug decades ago, their strategy was to combine it in a pill with 50 of hydrochlorothiazide plus the amiloride. Now, the 50 was a fairly high dose. And if you're going to be on a pill that combines 50 and this, that's a lot more diuretic than we prescribe routinely now. We routinely prescribe 25. So nobody was prescribing that combination pill. Well, what about marketing it as an add-on drug? They never really did that. They did their marketing as a combination pill, and then it just never made it. And it's an excellent drug, amiloride. It's an alternative to spironolactone, inexpensive, well tolerated, and effective. Um, so I would emphasize that more than the guidelines do. Finally, there's baxdrostat, which is a new class of aldosterone synthase inhibitors, which also block the synthesis of aldosterone. It works well. Its use will largely be for people whose hypertension is mediated by an excess of the hormone aldosterone produced by the adrenal gland. And it's probably best suited for that. It's a very expensive drug. They're not going to compare it to the amiloride or emphasizing other diuretics, but certainly where aldosterone is involved, it looks like a up and coming drug. Um, so let's move beyond the diuretics. We discussed a lot of that in the last podcast. So as I was saying, resistant hypertension, it's resistant to drugs that target the sodium volume mechanism and the renin-angiotensin mechanism. So we have to think of the sympathetic nervous system. And when we looked at the options in the guidelines, it said augment the diuretic, add drugs from that list. And if that doesn't work, consider renal denervation. Renal denervation is a procedure where they put a catheter into the arterial system and they slide the catheter to the kidney arteries, the artery to the left and right kidney. They zap those arteries, they zap the sympathetic nerves in those arteries, and that's supposed to lower blood pressure and reduce the need for additional medication. They're promoting it heavily. Um, Price for it somewhere between $20,000 and $28,000. Um, what does it do, and what is the alternative to it? Well, initially the study showed that it lowered blood pressure by 18 millimeters, 18, which is pretty good. But that was a study without a control group. So then they did studies with a control group, and they found that it lowered pressure by 10 millimeters. Well, that's still pretty good. But then they did a study where they used 24-hour blood pressure measurement as the outcome that they were measuring. And using the 24-hour blood pressure, how much does it lower blood pressure? 3 to 5 millimeters. That's all. It's an invasive procedure. It's a very expensive procedure. And it's a procedure that should be relegated to people who truly can't get under control. But I think we can do much better with the pills that are available. And in most cases, it shouldn't be necessary. And in many cases, we don't even know if it's going to do much anyway. So then what is the alternative in this group with hypertension resistant to the other two mechanisms? We're thinking sympathetic nervous system. And that's another discussion, what drives the sympathetic nervous system. That's a topic for another podcast. And there is a combination of pills that lowers pressure a lot more than that 3 to 5 millimeters. And that is the combination of two drug classes, a beta blocker and an alpha blocker. That's the sympathetic nervous system, adrenaline, noradrenaline, they increase cardiac output and they increase vasoconstriction, constriction of the arteries, which raises pressure. And the combination tackles the increased heart rate and cardiac output with the beta blocker and the increased peripheral arterial resistance with the alpha blocker. And what I like, and a combination that has not been studied much at all, and I'll explain why. Combination of a beta blocker and an alpha blocker. A beta blocker that's not metabolized the first round and gives a predictable blood level, and an alpha blocker as a separate medication, one of each. And there are only 3 studies of that combination. And here's a study that one of those 3 was our study. And if you look at the data, the blood pressure drop, in that case, it was with betaxolol and doxazosin, excellent response as compared to the diuretic, as compared to the ACE inhibitor, excellent response. And the other 2 studies also show comparably big responses. So I, for decades, have been using that combination for resistant hypertension with very good effect and well tolerated. One caution is the doxazosin comes as a 1, 2, 4, 8 milligrams, even up to 16. I never go to the high ones. Most patients respond to 1 or 2 milligrams. The one precaution that I take, it's not in the books, it's not in the guidelines, because of that first dose effect that we mentioned, I generally tell a patient to doxazosin, take only a half a pill the first day or 2. It reduces the risk of that exaggerated first dose effect. It's not common at that low dose. Half of 1 milligram makes it even less likely that it would happen. I've had some patients come back and they say, on the half a pill, my pressure was perfect. I never increased it to 1. So for doxazosin, I think the usual dose should be between a half of 1 milligram and 2 milligrams. So there is no half pill. 1 milligram pill, cut it in half the first day. After that, 1 milligram can increase it to 2 milligrams. The beta blocker that I like is bisoprolol. It's an excellent beta blocker, well absorbed, and the usual dose would be 2.5 or 5 milligrams, rarely 10 milligrams, usually 2.5 or 5 milligrams. That and the doxazosin can be taken together once a day, and they work together beautifully. So how come the doxazosin is not widely used or not more widely used than it is? I think it's another error in how it was marketed. It was marketed as a first step drug. They wanted it to be a first dose, a first drug option for anybody with hypertension. You get the big market. And a large study was done, the all-hat trial, and they found that it wasn't as effective as the usual first step drugs, the diuretic, calcium channel blocker, and ACE or ARB. And so at the end of the day, they could not market it as a first step drug. And they never bothered to study it. I did a small study with them, combining it with the beta blocker, and suggested, why not try combining them? But they never really pursued that. and they never studied it together with a beta blocker. It is a beautiful combination, and with a beta blocker like bisoprolol specifically, it's beautifully tolerated and more reliably in terms of the blood level achieved with the pill. Um, and unfortunately, also the beta blockers never did studies combining their beta blocker with an alpha blocker because beta blockers have been around forever. They're generic. No pharmaceutical company would bother to do that study. Um, and the only ones that were studied were the pills that have the two effects, which are carvedilol and mebendolol. And we had those limitations that we discussed. Finally, the renal denervation that we said. The guidelines recommend renal denervation. They don't recommend the combination of an alpha and beta blocker. And I think that is a major problem with the guidelines. Um, would you rather try a $25,000 procedure and if it doesn't work, then try an alpha and beta blocker? No. The alpha and beta combination is very effective and is worth trying. And it's much more effective, much less expensive. And if it doesn't work, then the question is, if the alpha and beta don't work, will the renal denervation lower the pressure? Nobody has ever studied that. My suspicion is if an alpha and beta blocker don't do the job, renal denervation won't do it anyway, because renal denervation focuses on the sympathetic nerves to the kidneys. The alpha and beta blocker pills are dealing with alpha and beta receptors throughout the body, the heart, the arteries, and the kidneys. So your doctor might not recommend this combination of bisoprolol and doxazosin. Um, let them see this podcast, and I've also written articles about it. And you may have to suggest it to your doctor. It's a beautiful combination in patients who have not responded to medications that target the sodium volume and the renin-angiotensin system. So to sum up, if your blood pressure is not controlled on the three drugs that the guidelines then call it resistant hypertension, the first thing they suggest is augment the diuretic. And as we discussed, given the 25 milligram dose of hydrochlorothiazide, if the sodium volume mechanism is the likely mechanism, it is not unreasonable to augment the diuretic as a second step rather than only as the fourth drug. And we have the potassium sparing diuretics that we discussed. And then you have the other agents that are listed, and we discussed some of them. Just going through that list, it mentions alpha blockers, it mentions beta blockers, but it doesn't mention the combination. It mentions the sympatholytic drugs that target the sympathetic nervous system, best known as clonidine, which I generally don't like to prescribe because it makes a lot of people tired and gives them a dry mouth. Other drugs like hydralazine and minoxidil, they are effective, but they often cause retention of fluid and the need for a big dose of diuretic to be taken with it. So some of the other lists in the list are very new and expensive. But with what we've described, tackling the three mechanisms, almost everybody should come under control. And if it doesn't, suggest the alpha blocker, beta blocker combination to your doctor. You may have to suggest it because, as I said, they just didn't do the studies for those unfortunate reasons. It's a beautiful combination, and you should almost never need the renal denervation because this works so much better than the other. And I hope you'll spread the word about these podcasts on the guidelines and hypertension to your friends and relatives. I think there's important information that a lot of doctors are not aware of. You may have to suggest things to your doctors. And also, If you have severe or resistant hypertension, your doctor must consider the possibility of things other than essential hypertension, so-called secondary hypertension. It could be a narrowing of the artery, a stenosis, a renal artery stenosis. The artery to the kidney is narrowed, which raises pressure. Could be hyperaldosteronism, where the adrenal glands produce too much aldosterone. It could be pheochromocytoma, a tumor that secretes adrenaline. So if you have severe or resistant hypertension, screening tests may be in order, up to the physician's judgment. Bottom line, though, we don't have to accept uncontrolled hypertension. We can control it in almost everybody. So that concludes this two-session podcast on the guidelines and medication treatment of hypertension. Please bring it to the attention of your friends and relatives and your doctors. And if you have any questions or comments, you can communicate through my website at drsamuelmann.com. And thank you for your time and attention.